Good morning, everyone. We'll get started in just a moment, letting people join. Good morning. Glad the chat's working. Okay, so welcome everyone to the Kentucky Harm Reduction and Recovery Community of Practice webinar series presented by Voices of Hope and the University of Kentucky Harm Reduction Hub. My name is Brooke West. I am a person in recovery and the training and education manager at Voices of Hope in Lexington, Kentucky. The goal for this webinar is to bring together a group to engage in training, share best practices, and network around a common interest. Today, the topic of our webinar is new psychoactive substances presented by Preston Tolbert, who is not only a PhD student at the University of Kentucky studying epidemiology and biostatistics within the College of Public Health, but also a research analyst with the Harm Reduction Hub. And we are so lucky to have Preston pulling a double shift on the webinar today, as he will be co-presenting the Harm Reduction Hub update before launching into his presentation describing new psychoactive substances currently observed in Kentucky and examining factors contributing to rapid changes in the landscape of these substances. Just a couple of housekeeping notes. If you are a peer support specialist interested in continuing education credit for this webinar, you need to complete the survey that we will place in the chat toward the end of this session. And as most of you have found, we have the chat feature on so you can participate during the webinar and ask questions. We really value your participation. So today's webinar begins with an update from the University of Kentucky Harm Reduction Hub, which is a transdisciplinary initiative to provide early insights into Kentucky street drug supply through the analysis of drug residue from used syringes. The Harm Reduction Hub has a dedicated drug analysis lab and staff, and they use a mass spectrometer, which is a fancy chemistry machine that identifies molecules, to test residue in syringes obtained from partner harm reduction agencies in the state, allowing for real-time monitoring of emerging drug threats. This syringe residue testing project analyzes trace amounts of drugs left in used syringes to detect new and emerging adulterants. So today's update from the Harm Reduction Hub will be presented as a conversation led by Casey Bitchek, a harm reductionist with over a decade of experience working in syringe services programs, advocacy organizations, and community-driven research studies, and is currently a community research associate at the Harm Reduction Hub. And Casey is joined by Preston. He earned a bachelor's degree in economics from Rutgers University and a master's degree in biostatistics from the University of Kentucky. He has worked in substance use research since 2021 and is currently investigating substance use among rural Appalachian populations with a particular focus on new psychoactive substances, including hemp-derived cannabinoids and kratom. So excited to have Preston, and welcome back, Casey. I'll turn it over to you all.
Thank you so much, Brooke. I will share my screen. Can everyone see this? Great. Okay. So today we are lucky enough to be joined by Preston, where we'll be having a conversation about the increase in synthetic cannabinoids, a word I always struggle to say. But before we do that, I'll give you a quick overview of the hub and of our testing results from March. So just an acknowledgement. Thank you so much to Vital Strategies for funding our work. Brooke did a wonderful job summarizing the hub for all of you, but just in case anyone is new to this webinar and unfamiliar with what the hub is, a little bit more information. We are a community service bringing together researchers, healthcare providers, and harm reductionists with the goal of providing early insights into Kentucky's street drug supply, which we do by analyzing residue in used syringes by using the mass spectrometer, our fancy chemistry machine. We work with 10 partner sites across 5 counties. Those counties are Fayette County, Jefferson County, Rowan County, Perry County, and Jessamine County. And then just a quick overview of our March testing results. There will be a full debrief that goes into county by county breakdowns and 6-month trends in our newsletter, which will be sent out this Friday. But just an overview of the top 10 most frequent substances identified in March across all sites. Methamphetamine was our most frequently identified substance in March at 60%, found in 60% of the syringes. Then fentanyl was found in a little under 40% of the syringes. Diphenhydramine is Benadryl, which was found in about 30%. 4-ANPP is a precursor to fentanyl and was found in about 25-26% of syringes. Dimethylsulfone is a bulking agent often used in methamphetamine, and we identified that in about 25% of the syringes. Lidocaine is a local anesthetic used to use as a bulking agent and to prolong the half-life and effects of many substances, including fentanyl and heroin, cocaine, and methamphetamine. D-mannitol is a sugar, it's a bulking agent. 6-monoacetylmorphine is a metabolite of heroin. Caffeine is caffeine. I don't think I need to explain that to anyone. And then acetaminophen is Tylenol. So that is what a quick overview of what we found. And Karen, I see that you have your hand raised. Is that intentional? Do you have a question? So Dustin too, and please, if anyone from the hub has, oh, okay, great. If anyone from the hub has anything to add, please feel free to, including you, Preston. Dustin's asking, no heroin at all. Is it all fentanyl? Yeah. Oh, I'm sorry. Oh my gosh, I'm so sorry, Kelly. Yes, diacetylmorphine is heroin, and the 6-monoacetylmorphine is a metabolite of heroin that indicates that there was some heroin in the syringes. And again, this is just the top 10 substances. There will be a further breakdown in our newsletter, county by county. And Preston, it looks like you might have something to add. Okay. Okay, thanks for asking, Dustin. All right. Okay, and so something that we did identify through some of our testing from a partner site in Jefferson County in March is a synthetic cannabinoid called 5-FADB. And Preston is here to talk with us about that and other synthetic cannabinoids. So I'm going to stop sharing so that you can see Preston and I as we have this conversation. And also, please feel free to drop questions in the chat as Preston and I are chatting. So Preston, I'll just start by asking, we don't often think of injection as a way that people use synthetic cannabinoids. What are your thoughts on this?
Yeah, it's a really unusual situation that that we've seen not only in Kentucky but also in some other places across the country as well over the past year, few years, and limited amounts. And before I even start getting on this, I do just always want to give a disclaimer whenever I give talks like this about my perspective real quick. Is that I approach this work as a researcher without lived experience of substance use, but my research is shaped by conversations I have with people who have lived or currently with living experience. And I ground my research in that expertise. No need to go too far into that, just always like giving that bit of a background and disclaimer. Back onto what you were saying though, Casey. Sorry for getting sidetracked. Yeah, with injection and these synthetic cannabinoids, it's super unusual. What I personally haven't heard is as to why anyone has done it before. We haven't had the chance to explicitly ask anyone, and I didn't see anything from research in the literature that's mentioned anything about it so far, other than seeing a couple case reports. A couple case reports of finding some contamination with some heroin, particularly like in Philadelphia. But these are very limited case reports of like case series of a couple people. My initial suspicion is that it might just be like direct preparation level contamination. But that's just a educated guess at the moment. We'd have to, maybe advise, advisory boards, and another thing that's great about this is we get to ask all of y'all. We're just very curious about this. Does anyone, first of all, have any has anyone heard about this before other than just the few of us? And if so, what are your guys' thoughts on this so far?
So, Preston and Casey, while people are answering in the chat, we had a question come through that what can you explain what a cannabinoid is, and is it the same thing as kratom?
Yeah, absolutely. So kratom and cannabinoids, very different in a whole host of ways, other than that they are both, substances that people use for, tons of different reasons. A cannabinoid is a big class of drugs that are characterized by activating particular receptors throughout your body. They typically are called CB1 and CB2. I'm not a biologist or a chemist, so I can't really go too far into that right now, but that's generally how they're categorized. And then kratom comes, and I'll go about this a bit more in depth later, but kratom is a plant from Southeast Asia, has a bunch of chemicals called alkaloids, which many of them act in a lot of ways like opiates. They work on same receptors in your body that a lot of opiates do. So very different in a lot of ways.
Uh, Amanda just dropped a question in the chat whether people have heard of anyone injecting cannabinoids and what their thoughts are on why this might be happening. I'm seeing a couple no's and not at all's. Um, please feel free to continue dropping your thoughts. Oh, I've never heard of anyone injecting it, just smoking it. Never heard of it. Sounds risky. I have not. So yeah, this is something new that we're seeing. And thank y'all for being in conversation with us about it. So I think you started to answer my next question, Preston. But if you can go a little bit more in, oh, sorry,
I'm sorry
Amanda.
to interrupt you, but we do have Sahara has said yes, she has heard of it. So, Sahara, as
Oh,
they're talking, if you want to put some thoughts in the chat
yeah,
about, maybe why, that would be great to hear. Sorry, Casey, you
yeah,
can.
absolutely. No, please. Yeah, absolutely, Sahara. We'd love to hear more about it and what your thoughts on why people are injecting it. Um, while Sahara and other folks are answering in the chat, Preston, can you explain a little bit more about what synthetic cannabinoids are and what the health concerns associated with them are?
Sure thing. There's a lot to go over, so feel free to stop me at any point as I start going through this. Uh, First, I'll explain just what synthetic cannabinoids are. I already gave a really quick primer, but I'll go a bit more in depth in a moment. And then I'll address the second question about health concerns after that. So, like I just mentioned previously, synthetic cannabinoids are, they fall under the big class of cannabinoids, these drugs that act on these particular receptors in your body. But they're actually completely synthesized in laboratory settings. They were originally developed back in as early as like the 60s by pharmaceutical companies trying to develop therapeutics for a whole host of different reasons. None really stuck. However, people knew that they produced intoxicating effects similar to a lot of other cannabis products, like Delta 9 THC. Um, However, one thing that's pretty different about these synthetic cannabinoids, other than just how they're produced, is how they're typically how they're found with respect with other chemicals. So when we talk about traditional cannabis products, this is a product that actually comes from the cannabis plant. And there you have delta 9 THC, which is that primary psychoactive chemical. It's also found with other chemicals like CBD as well. And the difference with that compared to synthetic ones is most of the time they're only having a derivative of one of these synthetic products that's supposed to be an analog to delta 9 THC in a lot of ways. And these synthetic products, they're found to be, more intense with the intoxicating effects a lot of the times, much more potent. And then the negative side effects have also been described to be much more potent and extreme as well. This falls under like GI complications, anxiety, psychosis. Not pleasant, but not nothing that we haven't heard about before in a lot of ways. Something else that's interesting about these synthetic products is that they don't have CBD in them most of the time. Unlike a traditional cannabis product that comes from the cannabis plant, while these synthetic cannabinoids are these like agonists that produce the subjective effects, CBD is an antagonist for those same receptors. It produces like this moderation effect when you have traditional when you're using these traditional cannabis products. It helps you know like I just said, moderates the potency of them. But without that in these synthetic products, there's not that like natural break in place. It just makes the actual subjective effects much more intense in a lot of ways. Um, and if anyone has any thoughts about that at all at the moment, I'm more than happy to take a break. But if not, we can start getting onto health concerns now.
Yeah. I will say, so in the chat, we had Sahara expand a little bit. It sounds like, Sahara, please correct me if I'm wrong. You may be talking about injecting kratom and not synthetic cannabinoids, but talking about injecting kratom to try to get over withdrawal symptoms and feel it a little more. And then Ryan shared that he had one participant at a local SSP mention in 3 years that they had injected synthetic cannabinoids. And then we also have a question in the chat from Dustin. Dustin is wondering if synthetic cannabinoids are used by vets like xylazine, whether they're for animals or humans.
Real quick to address Dustin, your comment about being used by veterans. And sorry, are we talking about kratom or synthetic cannabinoids at the moment, Dustin? I think we're talking about kratom, if I'm not mistaken, but not sure. Oh, the synthetic cannabinoids. Yeah, so I'll be able to talk about this a bit further in my conversation, but one of the big populations at risk are veterans in a lot of ways. They have much higher rates of synthetic cannabinoid use compared to other populations of individuals who use drugs. And there's been self-report reasons as to why that's the case. There's also some systematic reasons as to why that may be more common in that population than others, but I'll definitely be able to speak about that further during my talk.
Thank you, Preston. And then I just want to pull out that Kelly Harp, who is the Hub's lab tech, explained that synthetic cannabinoids were originally made for humans, but now fall under designer drugs that are federally banned. And then we have a question in the Q&A from Megan, who is asking, is it mainly synthetic cannabinoids that are being found or both natural and synthetic? So if you can maybe explain a little bit of a difference between the natural and synthetic cannabinoids, Preston.
Yeah. So, I mean, obviously, there's tons of natural cannabinoids that come from the cannabis plant that are being found all over the place. Synthetic cannabinoids are being found a lot as well. Traditionally, what we're seeing as of right now, compared to what we saw 20 years ago, is that the synthetic cannabinoids are pretty much being used exclusively in a role as an adulterant within these natural cannabis products to increase the potency, maybe reduce cost on their side as well. They're not being found by themselves like they were with like K2 and Spice back in the early mid 2000s.
Thank you. And then, sorry, I'm just trying to pull everything out of the chat. Andrew said that kratom has become really big in Kentucky. A lot of people are using it as a substitute and not a way to go through withdrawal. Hasn't heard of anyone injecting kratom. Can you explain? I'm just gonna say that we are discussing synthetic cannabinoids and not kratom at the moment, which is I'm so happy that people have so many questions about kratom. Maybe that is something to explore in a future webinar, but for the sake of not confusing anyone, I'm going to keep the focus on synthetic and the sake of time, keep the focus on synthetic cannabinoids for now. But thank you for the question, Andrew, and definitely will inform future webinars.
And Casey, I don't know if you noticed, because we had some questions come through in the Q&A. So Megan is asking, is it mainly synthetic cannabinoids that are being found, being injected, or also natural?
Yes. So Preston, I don't know if you want to jump in on that, but what we are finding is synthetic cannabinoids. I am not an expert, but I will say I have not heard of anyone injecting natural cannabinoids. I'm not saying that it doesn't happen, but I have not heard of it. Preston, I don't know if you want to add anything.
I mean, yeah, exactly right. I haven't seen reports of these natural cannabinoids being injected. I've seen, some scant reports of the synthetic ones being found in injection residue as well, though. So,
and then Jordan is asking what are some street names for synthetic cannabinoids. K2 and spice are the ones that I hear most often. Preston, I don't know if you have any others that you are aware of.
yeah. Don't have like intense lived experience, but I do know at least that like it was K2 and spice when people were actually seeking it out as like a primary drug. They don't really have slick names anymore. They have really long, gross chemical names nowadays, since they are primarily like adulterants nowadays. Like the big one that you hear is like 5F, ADB, and then there's another one, MDMB4, is the other big one that you see in a lot of these reports. Um, no real street names right now, but if anyone's got like street names for these brand new ones, love to hear that.
Jonna
Yeah.
put in the chat K2, spice, and synthetic marijuana. So I think we're on target there. All right. Do you want to speak a little bit about the health concerns associated with synthetic cannabinoids?
Yeah, totally. Synthetic cannabinoids, it's been pretty well characterized that they're actually quite risky to take compared to natural cannabinoids. A lot of the time we associate natural cannabinoids with not having many long-term health implications beyond maybe some early reports on maybe some, limited executive function and like working memory stuff. However, with synthetic cannabinoids, there's a lot more like acute injuries that have been observed. Biggest one that you'll see is, a bunch of cardiovascular and cardiac injuries that are associated with it. Hypertension, increased heart rate, arrhythmias. People have heart attacks off of these things. People have been reported to have died based off of synthetic cannabinoid use. Um, this is typically believed to be the case because the CB1 receptor, one of the receptors that's really commonly associated with cannabinoids in the body, um, that receptor is really prevalent in the cardiovascular system, and the CB1 activation has been found to mediate this like big cascading effect that leads to a lot of these different cardiovascular injuries and other dynamics like these arrhythmias. Um, Beyond just the cardiovascular stuff, though, there's been limited reporting of kidney function actually being impacted pretty severely in a lot of individuals. Where beyond just people who already have, who are at risk with some sort of pre-existing kidney injury, there have been people that have been found to receive acute kidney injuries that have otherwise healthy that had previously otherwise healthy kidneys, no other pre-existing conditions that would have uh, been supposed to contribute to that. And this is it's much less certain as to why this is going on than with the cardiovascular stuff. But people think that it may be due to the presence of, CB1 and 2 receptors in these kidney cells, these renal cells, along with really high concentrations of what are called endocannabinoids in your body in these renal cells. And not going to go too deep into it, but endocannabinoids, our bodies produce a lot of naturally occurring cannabinoids. Uh, And then when you start taking products like cannabis, those are called like exogenous cannabinoids, essentially. They're not like what's generally traditionally like produced in your body. But yeah, no, it's not like traditional cannabis products where it just makes you a little sick, might make you a little anxious. These have like real significant health implications and health risks.
Thank you so much, Preston. This has been such a wonderful discussion, and there's been so much participation in the chat. I appreciate it all. I'm going to pull out one more question from the chat, and then we'll transition to your presentation. So Jonna is asking whether synthetic cannabinoids are a full agonist.
Yeah, depends on what receptors we're talking about, obviously, but traditionally these synthetic cannabinoids, when compared to these natural occurring ones or even semi-synthetic ones, uh, continue to have presumed and described as having much higher, binding affinity. They're much more potent. A lot of the time they'll be described as full agonists.
Awesome. Thank you so much, Preston, and thank you to everyone who shared their experience and asked questions in the chat and the Q&A. That's all from the harm reduction. Well, I'm going to share my slides one more time so that you all can subscribe to our newsletter if you are not subscribed already, and then I'll pass it off to Preston. So I will leave this up for, for a minute or so. If you have any questions about this webinar or any other questions, thoughts, feedback for us, you can email us at ukharmreductionhub@uky.edu. I've provided 2 links where you can learn more about 5-FADB, the synthetic cannabinoid that we identified in March. And then you can scan the QR code to sign up for our newsletters. If you are not signed up already, I'll leave that up, as I said, for about 30 more seconds or so. And then we'll pass it along to Preston to talk more about psychoactive substances. I'm really excited for your presentation, Preston.
Of course. And after the presentation, if we have some more free time, I know we had some other questions that we were thinking about chatting about. Some really cool stuff that if we have time, I'd love to share with everyone else, time permitting, obviously. Just, I could talk about this all day if you gave me the opportunity.
Yeah, well, we appreciate it.
Yeah.
All right, stop sharing and pass it off to you. Thank you so much for having this discussion with me today.
Of course. Really appreciate it. Let's see. Let me get my slides together over here. And since I'm only working on a laptop right now, forgive me if the screen sharing is a little wonky at first, just trying to get this right. So I will open up the slide deck. Should I open it into presenter view first? I think so, right?
I think
Let me get,
so.
yeah. If it looks wrong, just let me know, guys. Let's see. So let me get to the share option now. Okay. Let me know if you guys can see the slide deck real quick.
Yes, it looks great.
Awesome. Alrighty, let me just hide these floating controls because they take up a ton of space on my screen. I'm not sure if you can see them.
We cannot see the floating controls, and I know the struggle of stacking the screen is real.
Yeah, it's no fun.
Yep.
No fun. Awesome. Alrighty, so today we're going to be talking about new psychoactive substances. Since I don't have any floating controls on my side, though, I'm not going to see if there's any questions popping up. So just Brooke, Casey, anyone, if you want to stop me partway through for questions, just let me know. Interrupt me. Have no issues with that, though. Alrighty, so real quick, just some disclosures. Views expressed in this presentation present my personal views based on my current expertise and don't represent the official views of the University of Kentucky. Got to say that all the time nowadays. Quick background about me. Brooke already covered this. Brooke and Casey covered this, but yeah, I did go to school, believe it or not, and I do research in here. Have some learning objectives we want to cover real quick. We're talking about defining and describing major new psychoactive substances currently observed in Kentucky. also want participants to be able to examine factors contributing to the rapid changes in the landscape of these new psychoactive substances, as well as evaluating potential public health responses to emerging new psychoactive substances. So, quick outline of how the talk is going to go. Going to give you guys a quick introduction as to what these products even are. After that, we're going to talk a bit about the substances of note that have been found in Kentucky, as well as addressing the legal landscape of these products, not only within Kentucky, but also at a federal level, because there's quite a bit of dynamic going on between the two of them, and seeing how they play out is going to be really interesting over the next year. Then I have some very preliminary data on new psychoactive substance use in Appalachian, Kentucky. This is with a study that we're doing along with a lot of other research with a large cohort. And then afterwards, talk about some future directions and elicit some ideas from you guys as to what ways we might be able to address these concerns. So, quick introduction into these products, real quick. New psychoactive substances, there's not like a one governing body that really solidifies what they are. The best one that a lot of people go off of right now, though, comes from the United Nations Office on Drugs and Crime. They call them as a substance of abuse, and this is the only quote I got in here as far as I'm aware. Just going to go through it real quick. It's a substance of abuse, either in a pure form or a preparation that is not controlled by the 1961 Convention on Narcotic Drugs or the 1971 Convention on Psychotropic Substances, but which may pose some public health threat. Um, Kind of ambiguous, kind of vague. It's essentially just the catch-all for stuff that we don't already know about very well. Traditionally, or in more common language, they're called designer drugs, legal highs, herbal highs as well. All different kinds of substances that kind of fall under this broad categorization that hasn't been investigated very thoroughly in a lot of other settings. Uh, Wanted to bring something up real quick. I don't know if you guys watch John Oliver, but he stole my thunder. Just a couple days ago, he posted his a new episode of his show about gas station drugs, which is one of the big themes of this talk today, or these gas station drugs that are going on. Had a full 30-minute special, and it actually did a great job introducing the topic, as well as the current concerns and the legal landscape regarding them. Uh, he also, if you know anything about John Oliver, he's always got a really absurd comedic twist to it. Would highly recommend. It's about 30 minutes. It's a great watch. Um, but yeah, of course, he presents that like 1 or 2 days before I give this talk. But always love to have more people learn about it and know about it. So there's a lot of new psychoactive substance groups that are traditionally accepted from this UNDOC group that I spoke about earlier. They're categorized actually by chemical structure from there. I've tried to, for a more of a public health perspective, try to group them into their subjective effects, where we traditionally all have, the same as we have with a lot of other substances. You have stimulants, depressants, and hallucinogens. And the ones that are in red are the ones that I'm going to be talking about, traditionally focusing on this depressant group. But if you look a bit thoroughly, you'll see that there's actually quite a bit of crossover between these substances falling into multiple subjective effect categories. It's another reason as to why they've been kind of hard to study. Quick example is, like kratom. It's been described as, a mild stimulant in low doses, but then have much more depressant opiate-like effects in higher doses. So it's a little harder to categorize just by its subjective effect. But I put this together as like just a quick little reference for people in case they want to have something to look back to real quick. So now I'm going to be talking about a couple new psychoactive substances that we've found in Kentucky over the past few years. The ones that I'm going to be talking about are kratom. We're also going to talk about hemp-derived cannabinoids as well as other synthetic and semi-synthetic cannabinoids. I'll get into the distinction between those a bit more formally compared to what we talked about in our Q&A. And then we'll also talk about tianeptine, which was very prevalent a few years ago. It's not as big nowadays, but you still hear it being talked about a lot in other parts of the country. So it's still important to still give it some attention. So we'll talk about kratom first. Kratom, it's prepared in a whole host of different forms. You can have it in leaves, in a ground powder. You can have it in pills, which are traditionally, powdered as well. You can also have it in these tinctures. But what it is it comes from the kratom plant, comes from Southeast Asia. There's been rough prevalence estimates of about 1% of the population has used it in the past year, and about 6% of the US population has a lifetime experience with it. Like I mentioned earlier, there's various routes of consumption associated with kratom. Uh, Most of the time, you're hearing it being used as pills nowadays. In some chats I've had with individuals over the past few months, because kratom's not a new product. People were using it, like as an herbal remedy a lot back in the 90s and 2000s, using it, for example, like in teas to help with anxiety, help with some, anxious effects with respect to that. It's not nearly as frequently used in that respect anymore. It's mostly used in that pill form nowadays that you get straight from a bottle at a gas station, for example. Kratom is one of those drugs, like I mentioned earlier, that is labeled one of these gas station drugs. You'll find it a lot of the time at a gas station, if not at the power wall with tobacco and other products. You'll find it with other medications, other supplements as well. A lot of the time it's called like a mood enhancer, a mood stabilizer, anxiety relief. There's a whole lot of ways that it's being labeled and sold to individuals. There's just not a whole lot of regulation, that binds them to say one particular thing or another. So they can kind of just throw whatever they want on there, and it's free game at the moment. And I'll go into some of the legal ramifications for why that's the case, and what may or may not be changing in the future. So yeah, like I said earlier, some stimulant-like effects in small quantities, but sedative-like effects in larger quantities. What kratom has is it contains mu opiate agonists. These are essentially chemicals that act on mu opiate receptors, the same ones that traditional opiates like heroin and fentanyl will act on. The big one that you'll hear most of the time nowadays is 7-OH. That is the one that's incredibly potent. It's gotten a lot of national attention for having a really substantial abuse potential. It's got reasonably poorly understood pharmacology, toxicology, abuse potential compared to a lot of other substances right now. It has been described, though, to have very similar withdrawal effects to opiate withdrawal. And I say that it's mild to moderate, but with some of these extracts, like 7-OH, as you hit it in more concentrated and higher and more potent doses, people have been describing it to even be related to, analogous to severe opiate withdrawal as well. This involves, the usual suspects: anxiety, sleep difficulty, body aches. There's also overdose possibilities with these isolates as well in some case reports. It's just not a safe drug in a lot of ways, and with the lack of regulatory oversight on these products right now, it's really hard to recommend that people can be using these in particularly safe manners right now. But we don't want to just tell people, I mean, you know, what's the best way to put this? It's just, never want to like use scare tactics for anyone, saying like don't do anything, but these are very dangerous products in particular circumstances. And so as it stands right now, it's not regulated by the FDA. There have been various bans and regulations in various states, though, but at a federal level, there just hasn't been much going on with it at the moment. Right here, as we have for a quick map going over some of the regulatory status as of 2025. I couldn't find 2026 data as of yet, but as of 2025, there were, what is it? Over half of the states in the US have some kind of scheduling or regulation in place. Multiple states have defined it as a Schedule 1 controlled substance. But a lot of the states don't have any sort of regulation at the moment, and with no federal regulation, it's kind of it's a free game in a lot of those places. And so, as to the legal status in Kentucky, this has changed a whole lot, even over the past few weeks. So, back in 2024, the state of Kentucky ended up imposing some restrictions to kratom products. Big things of note with respect to that regulation was that it was restricted to only be sold to individuals that are 21 years or older. And there was a restriction as to the amount of that 7-OH alkaloid, the one that's the really potent mu-opiate agonist. You can't have more than 2% of the product can be comprised of 7-OH. You also can't have any synthetic alkaloids, so no, there's no permissible way that you can like synthetically derive some of these products to make them more potent, which has been like a strategy that a lot of these kratom manufacturers and distributors have tried to get around 7-OH restrictions is with these synthetic alkaloids. So that was a way that Kentucky tried to clamp down on that before it even became an issue. They also required comprehensive ingredient lists and serving sizes to be required on these products. So they'll say, you only take like one pill per serving, or it gets absurd sometimes where they'll say you take an eighth of a pill, even though the pills are sometimes only scored into 4 quadrants or whatever. It's a pain in the butt, but at least there's requirements for serving sizes on a lot of these products. And then in November of last year, Governor Beshear made a statement wanting to classify 7-OH as a Schedule 1 drug in the state, but that's actually not even necessary anymore, because as of April 14th, the state, with their spending bill, they had a complete ban on distribution and sale of any kratom product. They didn't address possession, so there's no criminalization of personal use or possession of it, but you can't buy it anywhere according to the law as of now. Over the next few weeks, if it hasn't already been ripped off its shelves, it's going to be disappearing fast. So I mean that threw a monkey wrench into some research plans that some of us have had, but hopefully this ban can maybe reduce the risk that some people are being exposed to, but based off of some restrictions in the past, it remains to be seen how effective it's going to be. Moving on to hemp-derived cannabinoids, and I say hemp-derived, I'm also going to talk about synthetic and semi-synthetics here as well. Where hemp-derived cannabinoids are these products that are derived from the hemp plant, and it comes in various route of modalities. You see the cannabis drinks, have them as tinctures as well. You can also have them as edibles or as gummies. And what these products are, like I said, products that come from the hemp plant. The Farm Bill is how these products have traditionally been categorized and defined in the US, at least. In 2018, the Farm Bill is what allowed hemp products to be very prevalent and made it so that products which contain less than, that's greater than, apologies. You can't have more than 0.3% of delta 9 THC by dry weight in your product. However, all other THC products and other cannabinoids were not restricted in any capacity. That's how you have like very high concentration delta 8, delta 10, THCO, THCOA, HHC, a bunch of different cannabinoids. Sorry, just threw a bunch of names at y'all. But those products are able to be, bought in stores at essentially unlimited quantities at the moment, with barring any sort of state regulation because of the Farm Bill. There's been research that's stated that, prevalence is over 20% for the U.S. population just for 2022 use. Already went over some of the routes of administration. There's just an absolute ton of them. But the big ones that you see right now, like I mentioned earlier, are the THC drinks, the edibles and gummies as well, and tinctures to a lesser extent. They have very similar subjective effects to cannabis, as hemp-derived cannabinoids are traditionally, if we're thinking about like Delta 8, which is the most well-known one, it's been described to have much more mild or moderate effects compared to traditional Delta 9 products. But some of these semi-synthetic and fully synthetic cannabinoids, like I mentioned earlier, have been described as having even more potent effects than Delta 9 and natural cannabis products. So it's a little more difficult than just saying, hemp products are just like pot light, which you hear from some researchers. There's just countless numbers of hemp-derived cannabinoids out there. A lot of them are just low slight modifications to like delta 9 THC or delta 8 THC. A lot of the time they're CB1 and CB2 agonists. They'll either be partial agonists, sometimes all the way to full agonists in the synthetic varieties. And they have adverse effects for hemp-derived products. They've had adverse effects similar to natural cannabis products like anxiety, paranoia, and nausea. As for the legal status of these products, it's been quite varied because the Farm Bill has essentially made it a free-for-all. It's introduced this like backdoor access. State by state regulations vary wildly. But this is going to be changing in 2026, barring any sort of, executive action that happens. So I got a map right here. This is 2024 data, but it was a pretty good map that I had, and I wanted to show you guys. This is just an overview of how heavily or lightly restricted hemp-derived cannabinoids are in the United States. You see right now in Kentucky, they're fully legal, but you have other states, notably like California, they're illegal in a lot of respects. That's because they have legal recreational cannabis, and with the lack of regulation that's been going for these hemp-derived products, they've clamped down on them quite a bit more stringently than some states that don't have recreational access to natural cannabis. But overall, we see that it's just a total free-for-all in a same way that Kratom was in a lot of respects. And then right here, I want to go a bit more into synthetic cannabinoids, some numbers that we have from CFSRE. This is a lab that does some drug checking throughout the US. They get data from a whole host of sources. But the big synthetic cannabinoids that they've been finding in 2026, just to get some names on your guys' radar, you'll find 5-FADB being one of the big risers right now, as well as MDMB4. Those are the ones that you're going to be seeing a lot of the time that are going to be the synthetic cannabinoids that are found as the adulterants in traditional cannabis products. And if you look at the bottom right figure, I know it's kind of a lot of data right now, but this shows for each of these drugs, the trends, the number of detections that they've had from 2024 all the way up into 2026. And you can see that there's just been stratospheric rise in detections for these products in the past few years. They're way more prevalent now than they were back in 2024, 2023, 2022. One of the reasons that this is suspected to be happening is because the hemp-derived cannabinoids are so prevalent and there's such a lack of regulation as to how they're actually being, approved in the US and the level of scrutiny that they're having. I'll go a bit more into it further, but long story short is someone has a synthetic or a semi-synthetic cannabinoid or a hemp-derived cannabinoid they want to bring in the US. Essentially, they just have to submit to the FDA some kind of self-reported evidence that these products are safe, and then the FDA pretty much never looks at it again, and they don't require drug checking, drug testing in a lot of instances, unless states have their own requirements. Um, and that lack of oversight has been one of the main reasons that adulteration has been quite prevalent, is that some individuals are suspected to be adding these synthetic cannabinoids to make their hemp-derived products much more potent and much more addictive. And so some regulations with respect to hemp-derived cannabinoids in Kentucky. Back in 2024, we did put our own restrictions for hemp, where we have to specify particular approved sources, labeling, and certificates of analysis. Not all states have those certificate of analysis, which is how some of these hemp-derived cannabinoids are getting adulterated in certain states. Also, some restrictions on how they can actually be sold. So you can't buy buds or leaf in the US, and you have to be 21 years or older. Um, as of 2026, though, with the upcoming federal ban on hemp products, I'll go into that a bit further. Kentucky, since we have quite a large agricultural industry for hemp in the state, there are multiple bills that were proposed to try to allow exemptions for it, but none of them were passed. And so, with this upcoming federal ban that I'll talk about, uh, there's nothing at the moment, but the extent of which it's going to be enforced within the state of Kentucky just remains to be seen. It remains to be seen how much of a problem it's actually going to be at the moment. The last drug that I really wanted to talk about today was tianeptine. Big names that you hear about in the past were Neptune's Fix and Zaza were the big ones. Uh, as you can see, these were pills that you could buy from gas stations. There's another one of the drugs that's, these gas station drugs. And this is one that got the nickname of gas station heroin, if you've heard that a lot. It's what's called an atypical tricyclic antidepressant. It's a big name. Essentially, what it was a pharmaceutical that was developed in France, if I'm not mistaken. It's had a lot of therapeutic uses in Europe, but it hasn't been approved in the United States for any use. It has similar effects to opiates because it's a mu-opiate agonist. Has a whole host of different adverse effects like psychosis, nausea, sleep difficulties. Also been reports of people being able to overdose on these products. Been reported deaths attributed directly to the use of tianeptine. As I mentioned earlier, it's not regulated by the FDA, but there are a lot of state restrictions that are in place right now. As we see the legal status in various states as of 2025, some states have it regulated as a Schedule 1 substance. If we look in Kentucky, it's a Schedule 1 substance in the state as of 2023. But there's still a lot of states, especially in the Midwest, or not in the Midwest, forgive me, the Mountain Range and West Coast that have essentially no restrictions, as well as New England has very few restrictions as well. And yeah, as I said, in 2023, it was regulated as a Schedule 1 controlled substance. So yeah, manufacture, sale, and possession has been deemed illegal in the state. You just can't get it anymore. As I've talked to some community members about their experience with it over the past few years, and they'd all pretty much collectively said, "Yeah, we used it, as a uh, like a substitute for, opiates if I couldn't get it, or if it was just cheaper for some reason. So when it got restricted, it just dried up and they didn't even bother with it, which is why a lot of them had moved to kratom. So want to talk about the federal landscape of these products now and kind of how these got here and why they sit in this like gray market space in a lot of ways. The first one I want to talk about is the Dietary Supplement Health and Education Act. This was an act implemented in 1994. What it did was essentially allowed dietary supplements and health supplements to be much more accessible in the US. With a lot of these acts, it was done with great intentions to, improve individuals' health, give people more autonomy in what kind of products they could have access to. But there's very limited oversight of it, and there's big issue with it is it shifts the burden of proof of risk to the government, where they have to essentially say, uh, you know, the government has to prove that there's an actual I can't remember the exact language that's in the bill, but there has to be like immediate and impending danger or health risk to the population that they have to prove. Otherwise, these manufacturers or distributors, they can just sell it in the U.S. for the most part. Um, that's for a lot of these supplements, but the Farm Bill, as of 2018, that was the one that allowed a lot of these hemp-derived products and a lot of these THC products to be much more accessible in the US, where it only had specific regulations onto Delta 9 THC. Um, uh, but hemp was redefined federally in 2025. The big things that were defined in 2025 is that instead of making it so that any hemp-derived product cannot have more than 0.3% of delta 9 THC by dry weight, it defined it as zero point 0.9 or 0.3% of any THC product by dry weight, and then also said that you can't have more than, is it 4 milligrams of any THC product in any packaged product. So essentially, killing the hemp market. The entire hemp industry has been up in arms about this, lobbying very extensively to get this repealed. And there's been modifications proposed for 2026, but they haven't been successful. We've had legislators within our state being big proponents of trying to redefine this new definition, but that's all been unsuccessful at this point, and it remains to be seen how effective that's going to be, and if these 2026 changes do go into effect. They're scheduled for November, and so keep an eye out for that as to how the landscape will change in the future. So, having gone over that, now I want to talk a bit about some of the research that we've done in my research group for looking investigating new psychoactive substances. We've looked at individuals in Appalachian Kentucky. We have a project that, among many other aims and objectives, we're collecting data that's trying to assess hemp use among individuals who use drugs already in Appalachian Kentucky. We have a cohort of 731 individuals who use drugs to get high in Appalachian Kentucky across multiple counties. We're collecting data, every 6 months from these individuals, trying to get data for the next few years on this. And some very preliminary results that we've had and reported on already is that there have been associations between recent hemp-derived cannabinoid use and other various drugs. Some limited demographic measures have been associated with it. The big drug associations that we find are marijuana. Individuals who recently used hemp were found to be have 10 times greater odds to use marijuana. Not particularly surprising there, given just the overlap in their subjective effects. Hallucinogens were also found to be highly associated with recent hemp use. About over 2.5 times as likely to have used hallucinogens if you also used hemp products recently. One of note that we found was gabapentin. If you know what gabapentin is, it's It's a product that was traditionally used as a address neuropathic pain in a lot of individuals, but it was scheduled back in Kentucky in 2023. And it's been associated with increased risk of overdose in individuals who were using opiates already. So the increase in the odds of using gabapentin when people use hemp-derived cannabinoids is quite interesting. We've had some initial hypotheses within our group as to why this may be the case. Since gabapentin a lot of the time is used to treat pain, and some hemp products and cannabis products have been used for pain management as well. That's our initial guess as to why that may be happening, but it's still not conclusive yet. We need to actually chat with some individuals in the community as to why that may be the case, or if there's something we may be missing as to why that association may be present. However, that's the big one of concern right now. We're excited to collect more data on that as time goes on, as well as collect information as to not only prevalence of use when the 2026 restriction goes into place, but also follow up on some research that's been done by other individuals in our research group as to how people source these products. Where, for example, we saw that when gabapentin was scheduled, people didn't lower, or the overall prevalence of use didn't go down because of the scheduling of the drug. But what we did see was that people moved from getting it from legal sources to getting it from illegal sources, increasing the risk of adulteration as well, just increasing the general risk without actually decreasing use. And so we're curious to see if that will be mirrored with these hemp products. It's important for us to always be assessing how effective scheduling is, because at the end of the day, we're trying to help the community. And if scheduling isn't an effective way to be able to reduce harm in these communities, we need to figure out better ways to do it. Some demographic measures, though, real quick, that we saw that were also associated with hemp-derived cannabinoid use were that individuals who are younger were more likely to use hemp products recently, and then houselessness among our population much more likely to be associated with hemp use. Now, some future directions for what we're going on, and I kind of want to throw some questions to y'all actually, because I'm still early on in my training in a lot of respects, and so I'd love to elicit feedback from you guys as to what ways we can address some of these concerns in the future, and what ways we can try to understand this better. One thing that we obviously want to do is we don't just want to know what people are using and how much they're using, but why they're using them, right? Hemp-derived cannabinoids, in general populations, for example, have been described to be used for, pain management and anxiety relief, but that may not be the same among populations that are already using drugs, or among populations that may be injecting drugs. And so we want to understand the unique perspectives of different communities, and learn from them as to why different patterns and trends may or may not be appearing in certain groups. And we can, get that from community advisory boards we've used in the past. We could try to use more formalized focus groups in the future if that's a route we want to go down. And then, like I mentioned earlier, we have some survey measures that we've developed that we haven't reported data on. We're still collecting the first round, but we're trying to understand why people are using some of these hemp-derived products, as well as kratom in that cohort in Eastern Kentucky that I mentioned earlier. So after having consulted some advisory boards, we used their feedback to develop some formal survey items about the reasons for use in these communities. Another thing we want to do is collect data as time goes on, and as the legal landscape changes. We really need to understand how these trends develop, and then try to identify particular risk factors that may be associated with use of a lot of these products. And then, just like I said earlier, the policy implications on these different factors and trends, we really need to understand, because policy, a lot of the time it's being put in with good intentions, but a lot of the time it just doesn't have that effect. And a lot of the time these policies just hurt the communities. We've seen that too often already, where, misguided policies or, policies that are just not well drafted or didn't necessarily consult the right people end up harming the people that they're trying to help. Um, and then with some of these substances of note, for example, kratom or synthetic cannabinoids. We need more directed public health initiatives. Just earlier messaging, earlier reporting. We can use our drug checking services that we have, like we do with the Harm Reduction Hub or other agencies throughout the country, to try to be on the lookout for some uh, of these substances of note. For example, with the Harm Reduction Hub, we're finding medetomidine. We put out medetomidine flyers and notifications as we've detected it more in Jefferson County, for example. Or you guys saw our recent flyer on the synthetic cannabinoid 5-FADB. Just initiatives like that to increase awareness among communities, but also just trying to reinforce harm reduction techniques that we've heard, all throughout. That we're all familiar with, always use, don't use alone always. But we need, with these new substances that are constantly on the rise, and as we need to understand them more, I'm curious as to what your guys' thoughts are on ways that we can try to address harm reduction with these new psychoactive substances and trying beyond just the drug checking services that we have. Other than that, though, I want to leave some questions. If anyone has questions for me, and then also, like I said, eliciting some feedback on ways that we can try to, be better stewards of our data and better stewards for our communities and in public health. Always interested to hear what you guys have to say. But other than that, if you guys have any questions, I'd love to hear it.
Preston, we have one question on what about treatment related to these substances? Is that something anyone has ever looked at?
With treatment for these substances, yeah. So for kratom in particular, one thing that I've heard being thrown out a lot more frequently, since it is a mu opiate agonist, it works in the same way that a lot of other opiates do. Medication for opiate use disorder, MOUDs, are I've been hearing been recommended in a lot of situations for kratom use for people who have some kind of dependence that they've self-described, or if certain withdrawal strategies as well overlap very strongly with kratom. But the MOUD is the biggest thing I've heard right now for kratom use. As for synthetic cannabinoids, I haven't heard a whole lot, honestly, other than the traditional, don't use alone, with these being a lot more potent than they were back 10, 15, 20 years ago, at least for traditional cannabis products. And then also being adulterated with these synthetic cannabinoids, use lower doses. Don't use too much at one time. Always use with another person around. Is got to be hammered with natural cannabis now as well, more than it was in the past, because of the cardiovascular risks that have been associated with these synthetic cannabinoids. It's not a product that is necessarily safe to be using on your own like it was in the past. And then I will stop sharing right now so I can actually look at the questions as well. Let's see. Oh, well, there's a lot of stuff here. Wow. Give me a second.
Well, thank you, Preston. I don't know if you missed any questions. We did
I
have
just
some
pulled them up now.
discussions about you were kind of going back and forth about the dates with the kratom sales ban, and that
Yep.
the bill was passed. I think on your slide it said April 14th. Um,
Yeah, I think it was April 14th is when it was passed. I've seen April 30th as a date where it was like actually enacted, if I'm not mistaken. I can't exactly remember the specific dates. It was a couple weeks ago that it got through, veto attempts, and the state got it fully through though. It's within the past few weeks. So let's see. 1024, 1035. So what date did they ban all kratom? Yep. Bill is passed, but they still see it everywhere in gas station. Yep. It remains to be seen how heavily it's going to be enforced, as well as, getting things off the shelves. It takes time. And especially in more remote areas, it may be slower than it is in urban centers. Just difficult to be certain. And as for Googling, I did see, yeah, the January 1st, 2027. I was looking through like the legislation as of like yesterday, and I didn't see anything specific as to the exact day that it's going to be enacted, but we'll see. I'm not a lawyer at the end of the day, and so I know we have, some lawyers that work with, or we have a lawyer with the Harm Reduction Hub. I could have them take a look at it real quick and help me out, kind of disseminate it a bit better, because the legal jargon, looking through any sort of bill, if anyone has done it a whole lot before, they know how much of a pain in the butt it is. But then, let's see. Yeah, Samantha Finch, you said, synthetic substances are crazy. Someone gave my mom a kratom pill at work and she didn't know, and they told her it was just a dietary supplement. Oh God, I'm so sorry. That's not fair. She was telling me about the pill she took at work for energy when I asked her what it was because it sounded funny. I had to educate her and chastise her for taking things without doing research first. Yeah, I mean, that's one of the things that's very frustrating with, the Supplement Act. Is the labeling, they can just say, it's a mood enhancer, it's an energy booster, when really it's just an opiate, essentially, right? There's just so much less oversight than there is with pharmaceuticals or with other regulated substances at the moment. Not saying regulation or controlling, scheduling substances is always the best route, but at least it puts like some framework for us to move forward with in some respects. I don't love it in a lot of respects, but as it currently stands, it's such a free for all. It's just putting the public at risk in a lot of ways. Um, let's see, continuing education credit. Josiah said that they had a patient in their pharmacy years ago, told him that kratom saved their life, and they'd struggled with opiate addiction for years and came looking healthier than they'd ever seen them in years. And yeah, you hear that a lot with kratom as well. We're beyond just individuals who are, financially invested in kratom, who are lobbyists to make kratom legal, and lobby against bans in certain states. You hear a lot of individuals who have used it for opiate withdrawal, or to help them, at least to self-medicate in certain respects, to to help get off of opiates. And there, I mean, like that experience can't be understated, right? It's had real dramatic effect in a lot of people's lives. I focused a lot of the harms that a lot of these products pose and a lot of the risks that are associated with it. But at the end of the day, these products, depending on who you talk to, they may have been a lifesaver for some people, and we need to take that information, uh, along with the other information that we have about the harms, to try to balance what is the best way to move forward, and try to communicate to our communities about what communicate with, and try to collectively determine what the best way to move forward with these substances are. Let's see. Yeah, Dorothy said that when it first came to Pike County, they bought it in powder form, but yeah, they never opened the bag to try it. Yeah. Powder, it's a lot of the time it was seen in powder, either raw or in a pill form. But yeah, wouldn't personally recommend trying it if you've never done it before. Probably not the most fun time you'll ever have.
Well, thank you so much, Preston. I think I don't see any other questions coming through the chat, and I just put the link for the survey with the continuing education link. Or wait, the link for the survey for the continuing education credit in the chat. It looks like we got one more thing from John. My participant reported the withdrawal from these synthetic products are worse than any they have experienced. So yeah, it sounds like there's a whole spectrum of experiences related.
Yeah, and
with
that,
these
that's the
substances.
hard thing with a lot of these, a lot of people that do research on this call them these gray market products because of the nebulous regulations that exist with them right now. And sometimes, they're incredibly highly potent and create horrible withdrawal effects, or, they can induce overdose. But some people have fantastic experiences with them in right doses. We just need to figure out a way, like we said, collectively, the best way to move forward with this. We need to be able to have these conversations with communities, with lawmakers, and then just make more people aware about, the situation as a whole, about what these are and what they can and can't do, and how to move forward with it.
I appreciate what you said earlier about not wanting to just go straight to scare tactics. But there's a part of me when someone's like, here, you want to try this? I got it from the gas station. I tense up. So I think we do need to, be aware and be careful, try to stay informed,
Absolutely. And like the thing is they can be so innocuous. They can be so so inconspicuously packaged. You listen to some people who are in the distribution and sale of these, they're marketing a lot of these products to like soccer moms a lot of the time. They'll be like, oh, this is one to give you energy throughout the day working with your kids and whatnot, when they're just giving them an opiate like at the gas station. It is some nefarious stuff that's going on right now. And so, like I said, I hate scare tactics, but it's kind of a scary situation, especially with the total lack of oversight and the variability, the heterogeneity of the supply and the marketing, what you're going to get. We don't know a whole lot. Even, and this is something that I didn't speak on earlier. The packaging, you can get a package that'll have the exact same label in two different stores in the same town, but these labels were literally bought online from Chinese distributors, and then they're shipped over to the US, and then the US people put into the pills whatever they want. And so even the same package, if you think you have your own brand, it's probably not, unless you're getting it from the exact same store and that the store is getting it from the exact same seller, and that seller is the most straight up and honest person you've ever met. A lot of these products, because the lack of oversight and a lot of the labeling, it's just not there's just not a whole lot of consistency in the supply, even like between stores or even within stores. You can't necessarily know what you're taking at any given time, and you can't trust the labeling a lot of the time either.
Wow. Yeah, it's just a lot to absorb. But I'm so grateful that there are people like you out here studying this stuff, presenting on this stuff, trying to educate us, and thank you again for doing a double shift today here at the webinar.
My absolute pleasure. I love being able to have these opportunities to chat with and have these conversations with everyone in the community. I'd love to learn from you guys as well as just giving a talk as well. I get so much out of this every time from you guys.
Oh, thank you, Preston. And thanks, Casey and the Harm Reduction Hub. And I do want to, before we close out, give one last update just related to this webinar. This will continue to be presented in partnership between Voices of Hope and the University of Kentucky Harm Reduction Hub. Nothing about that collaboration is changing. But what is new is that Voices of Hope is now housing its trainings under an exciting new initiative called CREW, Krew, for the Kentucky Recovery Education and Work Skills Collaborative. And CREW will serve as the home for educational programs developed through collaboration between Voices of Hope and academic institutions. Through this initiative, we aim to intentionally blend lived experience with academic rigor to deliver high-quality, evidence-based trainings for peer supports and others who work alongside the recovery community. And so as we transition some logistical elements, you can expect to receive a few notification emails as we transition under the CREW umbrella. Thank you again, Preston and Casey and Amanda. And we will see you all June 2nd for our next episode, the first Tuesday of the month. Thanks, everybody, for being here.
And if anyone needs slides, feel free to contact me or anyone else who organizes the webinar. And if you guys ever want to contact me, have any questions about this, feel free to contact me at preston.tolbert@uky.edu, and that's in the slide deck as well if you guys if you guys need access to that for any reason.
Awesome. Yeah, we will add this to the slides to our webinar archive page at the Voices of Hope website, voicesofhopelex.org. All right. Thanks, everybody. Have a great day.